Here we go. Welcome to the McLean Hospital Crafting Support Project 2025 Family Webinar Series. I'm Dr. Julie McCarthy, and I'm a clinical psychologist and researcher at McLean Hospital. Tonight, I'm very excited to have you with us for a presentation on digital innovations for family members to support loved ones with psychosis with Dr. Benjamin Buck, Associate Professor from the University of North Carolina, Chapel Hill. So before we begin, I'll go over a few reminders. So folks are welcome to change their names for privacy or make questions or comments in the chat anonymously. Please feel free to enter any questions that you would like answered in the Q&A box, and we'll be answering questions at the end of the presentation. And we ask that you use the polls and chat for audience participation when appropriate and to share any comments, resources, etc. that you would like. We'll be recording the presentations and Q&A, and when recordings are available, we'll let attendees know. And to improve the webinar series, we encourage you to complete a very brief, anonymous, voluntary feedback survey to share your thoughts, preferences, and ideas for future webinars. This information really helps us for quality improvement and may be shared anonymously in the future with researchers or people who are interested in expanding support for family services. So I will put that in the chat if anyone needs to run early. Okay. And so to get started, I wanted to let folks know that, this is our August webinar in a series of webinars. And to get started with thinking about who's with us today, we'll also do a little poll in just a sec about who's here. And so first off, if you are here, I want you to think about what brings you to our webinar tonight. So let me launch our first poll. Go. And what I'd like you to do is just to answer, if you don't mind, what best describes your role: family member, person with lived experience with mental health challenges, clinician, or none of the above. It's possible we may have missed a category too, or if you have intersecting identities, feel free to select more than one option. All right, and so we'll close the poll in 3, 2, 1. Any last responses there? Get them in. Okay, so we have mostly family members with us tonight, 90% family members right now, and 10% people who have lived experience with mental health challenges. So thanks so much for being with us. All right, and why we even have this webinar series is because if you've been in a position yourself, or maybe someone you know, people all around us may be in need of mental health treatment. And for whatever reason, we may not always be in a position to get that treatment or help a loved one get that treatment, either due to access or not knowing how to navigate resources, not knowing what to do or say, or being concerned about doing the wrong thing potentially. And so anyway, we're here to bring together different evidence-based approaches or resources that could be helpful to you and your loved ones. So we have our webinar tonight, and we have 3 more after this. So we're in the second half of our series this year. And if folks are interested in past webinars, feel free to log on to our YouTube channel. And then we also have one-on-one coaching available to McLean families. And actually, this has been updated to Massachusetts families to have up to 12 weeks of one-on-one individual time-limited therapy with coaches like myself that taking an insurance-based model. So if you're interested in that and you have a loved one with psychosis and or substance use disorders, please feel free to get in touch if you're interested in learning more. All right, so in just a moment, we'll turn it over to Dr. Buck. I did have one other poll to kind of see how familiar folks are with this topic for today. And so let me bring this question up. So the question is, would you use a mobile app to learn skills to support a loved one? Yes, no, or maybe. We're not going to hold you to this. This is just kind of getting a sense of how comfortable and maybe how familiar people are with these types of new technologies. All right, I'll give folks another second or two to submit their answers, and we'll close the poll in 3, 2, 1. Okay, so it looks like about 55% of people would, yes, definitely use an app to support a loved one, and 45% are kind of in the maybe camp. So I think you're in the right place to want to try to learn a little bit more. So thanks so much for participating. All right, so I'm going to stop sharing my screen, and Dr. Buck, I welcome you to take it away.
Great. Thank you so much, for having me, Dr. McCarthy. This is a wonderful series and a wonderful resource for families. Just reviewing the speakers that y'all have had come, it's really, I'm pleased to be a part of it and excited to talk about this work and also to have a Q&A and conversation with folks in attendance today. So as you mentioned, I'll be talking about digital innovations for caregivers to young people with early psychosis, which is a program of research our team has been conducting for, I guess a little over 5 years now across 2 different institutions, University of Washington, where I was previously, and now with my team at the University of North Carolina at Chapel Hill. So there we go. Before I get started, just I'll lay out an agenda for what I'll cover today. So first, I'll give a bit of an introduction of who I am and kind of the team that put this work together. I'll provide the background and rationale for the project that I'll be going into most detail on today, which is the development of the Bolster mHealth intervention, which was the product of a multi-phase project combining qualitative interviews, prototyping, field trial, and a randomized controlled trial, which I'll go into in detail in a minute. And then I'll talk a little bit about conclusions from this work, both in terms of where things stand currently with Bolster and what I think are some kind of generalizable takeaway points in general for families to think about how to use digital resources, how to find them most effectively, and maximize their benefits. So first, a little bit about me and my team. So I'm a licensed clinical psychologist and conduct research. I'm a generalist clinical psychologist, or I received generalist training, but I'm also a specialty provider for individuals with psychosis and those at risk. I've worked in VA healthcare settings, coordinated specialty care, inpatient settings, and I've focused on schizophrenia spectrum disorders for just about all of my career. And the team that put together Bolster, I'll kind of recognize folks at the very end of the presentation, includes clinical psychologists, but also folks who have background in visual art and design, qualitative methodologists, and a team that's growing. So I want to recognize that this is the work of a variety of different backgrounds. I lead the early program, which is a program of research focused on moving upstream to solve some of the most kind of challenging access problems in mental health by addressing them sooner and expanding access through scalable digital technologies. And this program sort of based across 2 centers, previously at the BRIGHT Center, which stands for Behavioral Research in Technology and Engineering at the University of Washington, my former center and dear friends and colleagues with whom I still work with all the time, and also my new team at the University of North Carolina, both EPI and C, so the kind of team focused on early psychosis services in the state, as well as the Child and Adolescent Anxiety and Mood Disorders Program, CHAMP. So just kind of contextualize who am I and where am I coming from. So the background and rationale for this work. Obviously, folks here know how important family support is in mental health conditions, and particularly in early psychosis. We know that caregivers are absolutely critical to help seeking and outcomes. They're often the first to make contact with treatment providers to ensure young people make it to treatment and continue to engage. And an involved caregiver is linked with a variety of positive outcomes, so increased engagement in services, earlier engagement, which is an important predictor of outcomes in psychosis particularly, and also just improved outcomes overall. However, another thing that's familiar to this group, I'm sure, is that caregivers are struggling, or many oftentimes are struggling and need support. So these are just a couple of estimates from one particular study, but I think they illustrate the point of the amount of time caregivers spend. A significant amount of their time in caregiving related activities, and in it's oftentimes their income supporting individuals, helping them find treatment and providing support. But more than those kind of logistical concerns, it's the emotional burden and stress and difficulties in providing support, that it's really the norm that caregivers often report high levels of burnout in providing support. And one thing that's often missed is that a sizable proportion of family members and caregivers often experience clinically significant mental health symptoms of their own. Julie, you mentioned interlocking identities for attendees, which I appreciated. That grief is common, depressive symptoms, sometimes symptoms of post-traumatic stress. Overall, just that it's clear that the caregiving period, especially in the early course of identifying illness and connecting individuals to treatment, can be characterized by confusion, isolation, and high levels of distress. The state of affairs is particularly troubling because we have interventions that are effective, some of which you've heard from providers in this lecture series and some who are coming. We know that family interventions work for families affected by schizophrenia spectrum conditions. There's a variety of estimates of how much the risk for relapse is reduced from these interventions, but they also have significant benefits for family members themselves. And these are thought to work through both increasing family members' knowledge of psychosis, helping them cope effectively, and also providing guidance in how to communicate effectively with their loved one. However, very few caregivers receive these services, and unfortunately, this is kind of often the common refrain we hear in mental health services today, is that we really have difficulties with access and need more providers. Even in some studies providing sort of the gold standard specialty interventions for first episode psychosis with multi-component teams, we see something like 1 in 3 young adults with first episode psychosis have caregivers who receive sort of a full course of family psychoeducation. And that doesn't even touch the fact that many mental health care settings are not really, they're just not designed to support families or support caregivers directly. And so in addition to that, there are additional barriers just in getting into specialty settings where these providers, these specialty interventions are often offered at limited times by overextended providers and more often in resourced urban areas. So that means that a lot of folks have difficulty traveling there, or waiting a long time to be seen, or having a hard time fitting it into schedules when they're already, facing challenges, taking care of their loved one and managing work and all the other things that life brings along with it. And last, oftentimes the person with lived experience may have ambivalence about their family member being involved. Conflict may be, frequent for the family, and that can create challenges for caregivers getting support alongside the individual with lived experience. So as I mentioned, our team develops digital tools to solve mental health access problems, and I'm someone focused on psychosis. So several years ago, I guess this is 2018, 2019, we sought to collect data from caregivers to determine whether they're interested in using digital tools. And broadly, the answer is yes. I appreciate that you started the talk today with the poll with a very similar question. So we surveyed around 40 caregivers that members of our team worked with through the New Journeys programs of coordinated specialty care in Washington State. And first of all, in general, family members reported they were already using digital technologies in general, whether or not we had built them or who had built them. And when we asked them what kinds of features they would want in digital supports, they still wanted additional information about treatments and symptoms. And these were families who had been connected to care, but they still wanted kind of additional information and support. And in particular, another theme that emerged was information around how to communicate about the symptoms their loved one was experiencing, and skill practices for how to communicate with their loved one when facing really distressing symptoms. And one thing that also came out of this work was interest in particular in the modality of mobile health, or using apps as opposed to websites or other forms of digital technology. So why mobile health or mHealth? We know from these data points and also other existing research that mHealth is that mHealth is accessible broadly because smartphones are more widely owned than other internet-connected devices. There's less of a technology ownership gap between high-income and low-income families when it comes to owning smartphones. So these are a delivery method that can access more folks. They're often appealing to the caregiver population. Their smartphone digital mental health interventions in general tend to be acceptable and effective for self-management of a variety of mental health concerns as well. And part of their effectiveness comes from being available in real time, in real place, when the users are facing some challenges that are not unanticipated. They have their phone right there in their pocket or purse. So we were fortunate as a team to receive a pilot grant from NIMH, wherein our goal was to build a mobile health app specifically for caregivers to young people with early psychosis. And we set out from the beginning, broadly open-ended to just co-develop this with caregivers, but that we knew we wanted, given the problem we were aiming to solve, a couple of attributes. So first, we knew that we wanted this intervention to be scalable, given the fact that many of the access barriers come from issues with having sufficient providers available. So we wanted to have minimal staffing and infrastructure required for the intervention to be helpful. Obviously, we wanted it to be based on evidence-based principles, and also to build it consistent with the principles of user-centered design, which is an approach for developing a variety of innovations, most often technologies that just involve co-design with the target end user, to sit down with folks who are going to use the technology and say, what would you use? How does this look to you? What is confusing? Let me try as best we can to get behind your eyes to figure out what would be specifically useful to you. And so that was the approach that we took with developing Bolster. So now moving on to talk about Bolster and how it was developed. Again, I mentioned these 3 phases. So in phase 1, we conducted qualitative interviews and prototyping. So these were just in-depth, open-ended conversations with caregivers about their experiences, and also showing them a kind of early mock-up of the intervention we were kind of hatching in our minds to get feedback on how it looked and have them interact with a couple of interactive versions of that. We stratified recruitment by caregivers who were involved in the care of a loved one, about half of loved ones who were not connected to services or sort of suboptimally connected to services, and the other half that were involved in specialty mental health care. Second, we conducted a usability field trial. So that means having folks use the intervention for 1 week. I'll talk about that in more detail in a minute. And then last, tested to examine for evidence of efficacy and kind of whether folks use this type of intervention under real world conditions in a randomized controlled trial. So first, I'll talk about these qualitative interviews. I think this is this kind of approach. It's a really great place to start for any clinician or research team, to begin from a place of qualitative research, to sit down with individuals in the target population and just say, tell me your story. These were really rich conversations, and ones that we heard a lot of enthusiasm. Of course, these were folks who were participating in our study, but enthusiasm about the tool we were planning to build. To summarize some of the things that we learned from these conversations, I'm just going to talk about 2 particular prompts. One is asking folks to describe their unmet needs, and the other involved what we called a magic wand question, which is, you're holding your smartphone in your hand, you have a magic wand, and you wave it at your smartphone to create anything that could support your experience of supporting your loved one. What would you like to see? And as we analyzed each of these prompts, we realized that they really appeared to be 2 sides of the same coin, that folks were wanting to create with their magic wand things that met those unmet needs. And so we actually analyzed these 2 together. So the first theme, which came out of our qualitative analysis of these data, was communication coaching, which I mentioned before, and some of the qualitative work. So folks wanting to know, I really want support around how do I talk to my son or daughter, most of the time it's parents, when they say things to me that I don't understand or really scare me, things about religious figures or persecution. We had a few caregivers say, like, I just want a script. Like, give me, what do I say? I may not follow it literally, of course, but I just want to see some examples of what other people do here. That was, again, has been front and center from this program of work from the beginning. Also communicating with others about one's symptoms, which I think kind of indicates a desire for more knowledge and information. Also, general psychoeducation. It's not that the folks that we talked to couldn't find information online already, but that they wanted to be sure that the information that they found was reliable and coming from clinicians. And much of it they wanted to be actionable and kind of shaped to be more relevant to their particular situation, as opposed to just sort of textbook type of just, definitions and descriptions of these experiences. Next was a guide to services. We have a large, complicated, fragmented mental health care system, and our participants were understandably often worn down by that or confused by that and wanted information about, how do you identify an evidence-based provider? Who do we talk to? How do you start that process? What emergency or crisis resources are available? And then last, which I think this can sometimes be ambivalence from family members around this, support for their own coping, given the fact that for some, their focus is often, really lasered in on their loved one. But a few participants said to us, I really would like some support for myself, which aligned with, our team had developed digital technologies for self-management of various mental health conditions and related stress. So that spoke to that strength that we could use that in providing guidance and coping skills. So to recap our design objectives, first, the content areas from qualitative interviews just kind of popped right out with us. Again, with this word actionable coming up again and again, and figuring out how do we make this really something that folks can put to use in their lives. There that is. Again, I guess I got ahead of myself. Clear, actionable guidance. This is a point that has gotten a lot more interesting over the last few years. Participants described they wanted straightforward interactions with the app where information was just delivered in a clear manner. We actually had a section of the app that was proposed to be a rule-based chatbot. And so when I say rule-based, that means it's like something that we had written all the content. There's no AI in that chatbot, just to sort of create your own, or choose your own adventure based on your responses. Would you like help with X? If they hit yes, they get this response. If they say no, they get a different response. And that modality, that structure of chatting with the technology, was oftentimes greeted with confusion and discomfort from some of the folks, not everybody, but a few of the participants we talked to. I'm like, wait, am I talking to someone? Like, who am I talking to? Why? I'm talking to the app? Like, who is this person exactly? Which made a lot of sense in that really we're trying to provide a psychoeducational resource here, as opposed to, mimic interaction with some kind of provider exactly, but providing information that caregivers can deploy themselves. We stuck with kind of more simple interactions. And also participants wanted more interaction and personalization. So something from that chatbot side, but also to maintain privacy and security, which is always at the utmost center of the work that we do with building digital technologies. So the finished product is Bolster. It's currently an app for iOS. We have plans to expand it to Android that are starting quite soon. Bolster is built on the principles of family psychoeducation, support in cognitive behavioral therapy skills for stress for the caregiver to improve their wellness and help them manage stress effectively, and also coaching in how to communicate effectively, really with anybody, but especially how to communicate in some of these challenging situations that are brought up when someone's experiencing symptoms. So I think a really nice introduction is a video that we recorded to aid in recruitment and sharing about the intervention. So we've optimized the share for audio. Hopefully we don't have any issues.
Bolster is a smartphone app designed to support caregivers to young adults at risk for psychosis. Caregivers are essential supports to young adults with mental illness, but too often, caregivers lack the support they need. This is especially difficult for caregivers to individuals who have not yet engaged with mental health treatment. Bolster is the product of a multi-phase, user-centered design development process. The Bolster app aims to support caregivers as they support their loved ones in a few key ways: psychoeducation related to illness knowledge and communication skills, self-care strategies utilizing evidence-based principles, resources to help with treatment facilitation, and a tracking feature to monitor their loved one's symptoms. Caregivers can access short lessons and repeatable practices whenever they need.
Behavioral experiments involve creating situations that give us information about whether or not an illness-related belief is true. It's a way of collecting evidence. Only try this out if your loved one is open to it.
Bolster is a fully self-guided resource for caregivers. It can be accessed day or night, on the go, whenever it's needed.
I'll expand on a couple of these features as well and show a little bit more of a demo here. So the main sort of modality through which Bolster delivers information are lessons and practices, which was the term used in that video. So lessons are kind of introductory information provided about learning a new skill or new idea with a video presented by a clinician, that was me, and then a sort of straightforward swipeable carousel wherein users get sort of one idea introduced per screen. Practices, on the other hand, involve that sort of scaffolded interaction that you saw in the video that I'll show in a minute as well, where there's these sort of structured questions that are prompting caregivers to do particular practices or think about particular skills. Importantly, and this is where some of the privacy and security pieces come in, nothing that the user writes into the app, into these kind of free response fields, is saved anywhere in the app or on a database for our team or where anyone can view it. The only way that those interactions are saved is through a sort of private export, which I'll show in a minute, so that we made it such that the app was not collecting any identifiable information about the caregiver or the family member as they interacted with it to protect privacy. And for research purposes, we could follow usage data. So just like, what did folks look at? What did they use? And how long did they use it? But nothing about what they were interacting, how they were interacting with the system or what they were writing into it. Action plans. This really came from a couple of the caregivers who said, no, really, like, give me a bulleted list. These sort of action-oriented guides of things to consider doing in common challenging situations related to supporting an individual who's experiencing psychosis. And then last, these assessments. So this is the caregiver sort of tracking for themselves their own experience of their loved one's symptoms to see whether they could see improvements happening or when things have been more challenging and when they've been better. That has been somewhat of a divisive feature, not in the sense that some people were, not that it was controversial, but just that there's sort of people who use tracking and really enjoy it and find benefit from it, and a lot of folks who are just like, no, I'm here for the information that I can get from you. So, but still, for some participants, that's really an essential part of their experience of the intervention. So I'll drill down into lessons and practices a bit more. So as far as topics within psychoeducation, information about symptoms, about treatment, in communication coaching, there's sort of more general communication skills that are useful for anybody in being better active listener, asking open-ended kind of curious questions, and then specific skills around tough topics. So where conflict might come up, or where folks are in the midst of delusional symptoms that the caregiver is not sure how to engage or what questions to ask. Also self-care, so self-guided mindfulness exercises, cognitive restructuring under the sort of perspectives tab, and also habits, so kind of behavioral practices that folks could use to improve their wellness and manage stress. So getting into one particular example under communication coaching, this is an example of the menu that a user views for a kind of curious listening, curious questioning skill. So you can see here, I'm not going to go too much into the content, but I'll play just so you can see how those interactions
Symptoms
look.
like delusions.
Just a brief video that resembles what you saw in the trailer, and then just one sort of idea per screen. You can go back and forth and read just one point. Repeatedly in user-centered design, I've heard this with multiple populations. Folks say, like, don't make things wordy, don't overwhelm me with text. And so we tried to do that here. So lessons and practices can be approached separately, or users can continue on to a practice. So this one, which again resembles what we saw in the video a bit, provides a little intro and overview, and these scaffolded questions that guide a caregiver through a particular practice. What do you want to explore? What topic are you thinking about? And so you can see in the purple boxes there, the text that the user put in is temporarily viewable there for them to kind of scaffold their interactions. This is guiding them through thinking about how to generate some curious questions to kind of approach learning more about one's symptoms, and also to encourage the loved one to, question those symptoms as well a bit, or their assumptions underlying them. And last, there's a summary and recap at the end of a practice where users can take a look at what they wrote and review it. This is how the private export works. If you click Save to PDF, you can export the text that you wrote just onto your device, or through text message to yourself, or an email to yourself. But that information is not uploaded anywhere that we can see. It just stays with the caregiver. So once we had that full version of Bolster built, we wanted to test to see if it worked and if it might break when deployed. So we conducted a usability field trial, which basically describes, rather than doing usability testing in the laboratory, we wanted to get it out into the world so folks are actually using it on the bus or while they're eating breakfast on their own devices and not in the laboratory. And so for 1 week, caregivers, and these were folks who were already connected to specialty psychosis services, were given access to Bolster. And we recruited everyone remotely and installed the app remotely, which is another important piece to kind of learn about whether that was feasible. And we provided them outreach to support and check in if the app wasn't functioning. We collected data related to use of the app, so what sections did they review, and also some standardized usability scales, and sort of briefly some data about change in the outcomes that we were aiming to affect with this intervention. So just quickly to summarize this trial, these are described in a paper in JMIR Mental Health. All participants who installed Bolster completed the study and all assessments. So the feedback that we got was not just for folks who stuck around because they liked the app, it was really from everyone. And so during that 1 week period, again, it's not the most ecologically valid, it's just a sort of 1 week fishbowl period, I suppose. But participants opened the app on about 2/3 of days that it was available to them. And on use days, meaning on days that they opened it, this was for about 26 minutes per use day. And they used a high number of lessons and practices, so got a good flavor of the app and were interested in exploring. They rated it as highly usable overall. Just about all reported that they would continue to use Bolster and recommend it to another caregiver. That one person is sort of a neutral response, not a disagree, but that they were sort of neutral about those items. And interestingly, this stuck out to us in terms of thinking about implementation. None of our participants said that they felt they would need a technical person's help to use it. So I think that spoke to what we were aiming to do with user-centered design to ensure this was really straightforward to use, so that you didn't need to have somebody, sort of geek squad teaching you how to use this thing, which is making it really straightforward. And so we also collected some of our outcomes. I'm going to get briefly statistical here in reporting effect sizes. We'll just kind of break them out in terms of large effects, medium, and small. So, we didn't really expect to see changes over a 1-week period, but I think the fact that we saw some of these speaks to the fact that a lot of the family members we recruited really felt aided by this resource, that they felt like, okay, I've got something, I'm trying something new, I've got some support. And so what we found was significant reductions in psychological morbidity. It's kind of fancy term for symptoms of anxiety and low mood, kind of symptoms of stress more generally. And medium effects in changes in how distressed they were about their loved one's illness. Illness coherence describes how well they felt they understood their loved one's symptoms and that they made sense to them. Appraisals of their loved one's illness kind of becoming more recovery oriented, feeling more self-efficacy around coping, and also rating improvements in their own family communication. Interestingly, we didn't see much of an effect at all around psychosis knowledge. I think part of this likely comes from the fact that we were recruiting caregivers who had already been supporting their loved one for quite some time and also were connected to services. So it seems like that wasn't the sort of mechanism there. Again, not over-interpreting these, but just seeing that there was a signal of benefit during that field trial. So to get more than just that, very preliminary signal, we conducted a randomized controlled trial where we recruited 60 caregivers to loved ones who were not connected to specialty mental health services. So we're really focused on linkage, getting folks into these sort of specialty settings. And in that randomized controlled trial, this was a 3-month period, we recruited 60 caregivers, and they were randomized at a rate of 2-to-1, either to receive Bolster or to a control arm. In the Bolster arm, they received Bolster, of course, and also a bolus of online resources from advocacy organizations and scientific organizations around caregiving, psychosis, and information that sort of what we thought matched like online resources as usual. And then in the control arm, they just got that sort of bolus of online supports. Again, we assessed acceptability, usability, usage, and preliminary efficacy, because this is not a large trial that definitively answers, effectiveness by that sort of scientific standard. This is really a pilot RCT to inform whether we ought to do a large trial. So in our results, we found a high degree of participant retention. This was nationwide remote recruitment. So we recruited folks in both the Bolster, so both people who were randomized to receive Bolster and control. There's a high degree of retention, folks coming back and completing their 12-week assessments. Participants opened Bolster across the entire 3-month study period on about 30% of days that it was available to them. That, of course, is lower than the field trial, but this is a much longer period of time. And that's, when you think about over the course of a 3-month period, that's a sizable chunk of time. And also we had about 70% of the sample was still opening the app in the kind of final 2 weeks of the study. So it wasn't, the modal usage of most apps on the market is 1. Most of the time folks download, sort of look at something and jettison it. But we found really sticky usage of Bolster. So on use days, it was for on average about a little over 10 minutes a day. They completed a high number of lessons and practices in the app, and again, found it usable and acceptable overall. Most reporting that they would continue to use Bolster. Again, some of the folks who didn't endorse this item said they were sort of neutral about it. And most also reporting that they would recommend it to another caregiver. As far as results in this trial, we found promising benefits relative to the control arm. So baseline pre-post effects that were medium to large, and for some that were substantially larger than for the control arm. in things like family communication, psychological morbidity, coping self-efficacy, illness coherence, and emotional impact of illness. And again, I mentioned this sort of statistical standard of a large trial. So a pilot, we didn't necessarily expect that we would have statistical significance in change between the two conditions. And we found that in particular in two outcomes where there were real divergence between the arms in terms of psychological morbidity and emotional impact of illness. So it's the caregiver's emotional well-being that we were seeing the kind of largest changes. And also, because we were focused on linkage, we also collected information about the frequency with which family members reported that their loved one was hospitalized during the study period, or visited the ED, or accessed some kind of counseling or psychotherapy, or some kind of meeting with a psychiatric medication provider. And again, here we found that participants in the Bolster arm were sort of less likely to report that their loved one was hospitalized, and more likely to report that they had access to psychotherapy or counseling, and or med management, and the counseling variable was actually statistically significantly different. Otherwise, we're just kind of getting a sense of broad effects to inform a larger study, but that one stood out as differing between arms. So to summarize, Bolster was constructed based on caregiver input, really kind of partnering with caregivers. It was usable and acceptable in a field trial, and it has promising efficacy. So now to conclude, I want to talk a little bit about where we are with Bolster today, and also given the nature of this webinar and the audience here today, I want to talk a little bit about how to learn from these results for the use of all kinds of digital resources and what digital resources might actually provide. So first, to conclude, it appears to be the case that self-guided mobile health as a psychoeducational support is acceptable, it's usable, and it shows promising effectiveness in supporting families affected by psychosis. In particular, it appears in reducing psychological morbidity, improving family communication, and increasing patient engagement. So in many ways, kind of aligning with the research evidence on family psychoeducation. Bolster is one example of taking that approach of a mobile health app intervention for caregivers. It's the only of its kind that we're aware of for caregivers to young people with early psychosis. So we're excited about this as a tool to get out there. So what happens next? How can we kind of learn from what we've done? There are additional studies on Bolster that have recently completed, that are underway or proposed, and that pertains primarily to a couple of these questions around infrastructure and implementation and how this can be delivered, and also, a large, fully powered trial to confirm the evidence for this approach. But a couple of the questions left to determine involve developing a human support or coach role. Given the fact that Bolster was largely self-guided, it appears to be the case that it doesn't depend on a human support or coach role like some other digital interventions do. However, there's a lot of evidence to suggest that this kind of role can improve engagement and benefit. But we've conducted some work to develop that role and piloted it in a small study that's kind of just wrapped up and talk about today, but will be kind of coming soon. And also thinking about how this can be implemented and sustained. So we've considered and are in the works of trying to figure out how to deliver this within early psychosis care networks, talking with our partners in North Carolina in particular, and also thinking about whether it might be possible to deliver this in partnership with advocacy organizations. There remain some questions about implementation and sustainment, how to make sure that the app continues to function and that there's folks who can respond to the phone call if things break down. But overall, these results demonstrate the value of self-guided digital supports. And so I think an important kind of meta question is, what do these studies teach us about caregiving and digital tools now that I hope have some kind of, takeaway for you all in attendance today to think about, what do digital interventions provide, and how might I kind of learn from that with the resources that I've accessed, or how I'm navigating online resources to learn from that. And I think what we saw with Bolster was that this mHealth intervention really provided structure and routine to follow through on new information. You know, you likely heard this from providers about the importance of between session practice, that technologies can really kind of replicate providing some scaffolding and support for caregivers to self-guide their carrying out some of these practices as well. I see a hand raised. I'll get to questions in a minute. I'm excited to talk more. Also, ensuring that information is reliable and evidence-based. So, you know, we are clinicians and researchers, and so we based everything we built on research evidence. So I think the last point here also is what in the digital mental health world we call supportive accountability. So Bolster provided reminders, accountability, and reminders. And folks are busy. There's kind of a sad irony that the strain and busyness of caregiving can often prevent folks from being able to use resources, and in addition to just difficulty of how busy folks are in life, that I think Bolster allowed folks kind of reminder and ability to carve out space to use some of these tools. So how can you use this? There's plentiful information online about caregiving and psychosis. How do you maximize benefits from things you can find online? I'd say, you know, take advantage of the fact that there's multiple sources out there. I know it's not always the most satisfying. We've heard from folks that they wanted this kind of self-guided mobile health support, but to pull together multiple sources to find what resonates with you and also across these settings, and to do so to rely on advocacy and scientific organizations that have, you know, proven track record, and hear from, you know, voices of people with lived experience. For example, NAMI Family to Family, which I'm sure many folks here are familiar with, is a, you know, synchronous group that has an evidence base and has provided support to many, many caregivers and family members. Also Mental Health America, folks there I've worked with on a couple of projects. Spent a ton of time thinking about how to create resources that are maximally useful. Also Early Psychosis Network resources, even if you may not be connected with that particular care setting. In North Carolina, we're working on this, pulling together what online resources exist, and also in Washington State, there's a great collection from the Spirit Lab around this. I think you all have heard from Sarah Kapelovich before, and perhaps about her program Psychosis Reach, which is a really excellent program as well. And I think this is, you know, entirely understandable. But to try as best as one can, I mean, this is like absolutely, I can identify with this, exactly kind of how I think about some of these things, to try to just take one step at a time, as opposed to getting off down the road of what particular signs or symptoms might mean for a loved one's future. This is really much, much easier to say than do, but to kind of remember that there are many different pathways that recovery can take, and that recovery is the norm for most people. For young people who experience early signs and symptoms, you know, it's most often the case that folks recover. To really just pay attention to what's happened recently and what needs to be done, but to hopefully, you know, resist that degree of overwhelm to the extent possible. Okay, so that concludes a couple of points about what we think we've learned, Bolster as a resource, and I, you know, want to recognize the team and the funders who supported this work. Really grateful to all of the names and folks on the slide. So I apologize, I saw hands, saw questions. Can take some time to answer these now.
Great. Thank you so much for that amazing presentation. And yes, we can start with our Q&A, and then we'll save a couple of minutes at the end for closing remarks. So the first question is about, you know, to what extent this type of technology or digital health apps in general about psychosis could maybe be helpful to law enforcement potentially. Because, you know, this person says that, you know, reaching out to law enforcement, calling 911 during a crisis, sometimes personnel may not fully understand psychosis, and, you know, what opportunities do you see there?
That's an excellent question. I could pull up in chat and see who asked that. It's a really great thought. I think so. Yeah, my short answer is yes. I think that's a great observation. I think the longer answer is that I think why Bolster resonates. So, I conduct a lot of digital mental health research. I think one reason Bolster really resonates is because of where caregivers, are or are not supported in the mental health care system. That, the mental health care system is designed to provide services to that identified individual. And, with some exceptions, in general, there isn't sort of this like pathway for caregivers to get their direct support. So I think that's part of why Bolster has been really compelling, I think even relative to other digital interventions that our team has worked on. And so you can start taking additional steps with that little insight to think about, or big insight, I guess, of who else is not kind of receiving it doesn't have a kind of mechanism for psychoeducation,
Sure.
who has a lot of contact with folks who are experiencing symptoms. So one pathway that we considered and talked with a couple of folks around this that we haven't quite worked out, and there's a lot of work and a lot of directions we want to go, but was actually to talk with faith-based leaders as well. It's another population of folks who communities often look to say, like, this is going on with my loved one. What's going on? How do I help them? And often serve in kind of a mental health role, in not as a licensed provider, but sort of provide those resources and information. And that was something that when we talked to a couple of different faith-based organizations, they said this would be really useful. Part of the challenge there is how there's so many heterogeneous concerns that those folks encounter that there wasn't really ever enough of that critical mass of like, really, we're seeing a lot of folks who have suspected psychosis. It was lots of other concerns, but like the handful of people that they could identify who fit our description. Law enforcement, that's a really excellent suggestion. I think you'd want to change, there's plenty you'd want to change in the app, of course. But I think a couple of those key points around communication, they're sort of similar to mental health first aid skills, like that which are things that, you want a variety of providers and support people to learn. So that's a great point. Something for me to consider and put on the whiteboard, I think.
Yeah, definitely. Thank you.
Yeah.
So there was a question in the chat about creating an Android version. Yes, I think you had mentioned that that's in the works. Someone was asking if Bolster was available now in the App Store.
It is not.
Okay.
Just for now, we have kind of the mechanisms, and I mentioned these kind of questions around infrastructure,
Right.
that we have a sort of mechanisms in place for governance of deployment of this in research and not through just kind of out in the world delivery. That's the vision, though. I mean, I think the part of the point of having a scalable intervention is that it can reach as many folks as possible. So I mentioned that we've had conversations with state, partners through government organizations and also through advocacy organizations of places that could kind of have the right mechanisms in place to deliver that kind of resource.
Right.
So that's sort of the way we're thinking about it now. The implementation of a lot of digital mental health resources when there's kind of an identified clinical diagnosis can take a lot of, I could get into the whole tangent about this, but is often to go through like the sort of reimbursements for the activities of the provider that is delivering that service. Caregivers are a little different. And I think we designed this intervention specifically to be scalable. So the idea is that this could be self-guided, but there still need to be some elements of kind of implementation and sustainment that have to be built before this is delivered outside of the context of research. But that's the vision, that's the goal.
So we'll stay tuned.
Yes.
Another question was from actually one of our former speakers. Would Bolster potentially be effective for caregivers of relatives who have experienced multiple episodes of psychosis beyond the first or early psychosis stage?
That's a great question. Yeah, I think so. I can't say definitively because we haven't done the studies, but the principles around these interventions are very similar. I mean, there are some slight differences in the sense that we're talking about, a number of different diagnostic paths that was kind of a first episode might take. Whereas if, someone has a chronic diagnosis of schizophrenia, for example, like that that those sections of the app wouldn't be quite as relevant. But yeah, as far as the principles around effective communication, support,
Certainly.
positive activity scheduling, all the wellness, kind of self-care and stress management stuff, all that absolutely
Transferable.
applies. So yeah, I mean, we're in terms of some of the study, I mentioned studies that are ongoing and proposed. We've thought about deployments both kind of simultaneously. I'm working on some work around thinking about how to adapt this for other populations, potentially younger kind of identified patients or folks with lived experience and parents, or other clinical populations. But then also, I think just for Bolster itself, thinking about broadening a little bit to think about serious mental illness as a whole.
Yeah, definitely. Thank you.
So that's a great
So
question.
speaking of all those studies, one person, and I'm sure multiple people are wondering, how can a loved one or caregiver enter the research
That's a
groups or
great
studies?
question. So yeah, so I'm just trying to think like literally of current, so we don't
If you have any
presently have
opportunities.
studies running at the moment. There are a couple planned. There's one that we are launching right now in North Carolina to kind of learn specifically about how this could be implemented within the context of kind of statewide technical assistance for early psychosis. We're partnering with state Department of Health and Human Services in North Carolina, who are really excellent and forward-thinking folks, to put this together and sort of pilot how this would be embedded in our early psychosis program outreach and learn from how do we make the resources really targeted in North Carolina so they're maximally useful. So that's coming soon. If any folks on the call are from North Carolina, I suspect most folks are local to Massachusetts, but so that's one. And then also, as I said, we're hoping to launch that larger clinical trial down the road, thinking about other applications with advocacy organizations. I would say if folks are interested, if they have, I don't know if given my email address, but you can, if you're interested. We won't have opportunities in the immediate term, but I will say we've posted those through social media advertising and through Google search. So I hope that you would come across those. Also, PepNet is another resource that when we're doing nationwide recruitment, some of these will be statewide, but when we're doing nationwide recruitment, we've talked about recruiting through PepNet. So if family members are connected to that listserv in some way, or to clinicians who are on it, I think that's another way to hear about it. We'll be, sort of blasting folks when we do any nationwide recruitment.
Wonderful. Thank you so much. I just put your email in the chat. And so I'm going to close out with some parting comments. Thank you again, Dr. Beck. This was really, really wonderful. And I can't wait to see where the research goes next.
Thank you for having me.
Yeah. So in terms of folks who are a little bit more local to McLean, if you are looking for support, there are a number of groups on campus or virtual that could be of interest to you with respect to psychosis, mental health broadly, et cetera. And if you wouldn't mind taking a moment when we still have you before 6 o'clock, we would love to hear your feedback on what you thought about tonight's presentation, the series in general, and what you might like to hear about next. So feel free to check that out. It's an anonymous, pretty brief survey, and is a chance to provide your input into our resource in the webinar form. And then I just want to say thank you so much to the folks who have made this work possible, and special thanks to our donors. And our next family webinar will be next month, Thursday, September 11th from 5 to 6 p.m. Eastern Time on empowering families with psychoeducation multifamily groups with Rebecca James and Sarah Lynch from the Peer Training Institute up in Maine. So thank you. If you have any questions for me, let me know. My email is jmccarthy@mclean.harvard.edu. I've also put Dr. Buck's email in the chat. And we hope you have a wonderful rest of the night. Take care.